Good evening, everyone. Welcome to the ISU, USI ISU webinar. This webinar is on uro-oncology. And happy to welcome you all for this other interesting uro-oncology webinar. We have this webinar on testicular cancer. Though we see less cases, and most of these cases goes to specialized centers, and it is very important, especially for the postgraduates, to know about the way we manage these testicular cancers. Though the advanced stages are still in the hands of medical and radiation oncologists. I hope this is going to be a very interesting webinar because Dr. Gagan, who is the convener for this webinar, has selected a very esteemed and highly great faculty for this session. Now, before we start, Dr. Gagan, I welcome Dr. Uttam Mitesa, who is the Honorary Secretary of Urological Society of India. Welcome, sir. I request you to give your opening remarks.
I suggest Dr. Gagan should introduce there are so many overseas faculties. So I think he should introduce the overseas faculty, then I'll address. That will be better.
Sure. Dr. Gagan, over to you.
Yeah. You need to unmute. Huh?
Yeah. Ladies and gentlemen, thank you so much for joining this evening for this webinar. And I would like to thank the Indian School of Urology for giving me the opportunity to convene this. And we actually have a masters in the field of testicular cancer all come here for this evening. And a special thanks to Professor Aditya Bagrodia, who's from UC San Diego, a dear friend, and immense work on testicular cancer, particularly in miRNA, which, as we'll soon see from his talk, is actually shaping the management of testicular cancer. And also thank you, Dr. Valentina from San Rafael, Italy. And we had the we had the good fortune of working together on a paper on epidemiology that finally made it into European urology. And this probably is the most updated version of understanding the etiology of testicular cancer, the epidemiology, and also about the rising concern that probably the incidence of testicular cancer is rising in some parts of the world. And all my dear friends from India and from the Urological Society of India, I welcome you all.
Thanks, Dr. Gagan.
Yeah.
Now I request Honorary Secretary Dr. Uttam Sapri.
Thank you, everybody. Thank you, Dr. Surya. I think Dr. Sujata has disappeared, and he is still there.
Madam is there. Madam has joined.
He is there. Madam is still there. So only thing is, the timing of this webinar is a little bit odd in the sense we are going to have the subspecialty section of uro-oncology meeting just 2 days after this webinar. So that is the only odd point I could say. And as you have already told, this is a very rare tumor, maybe less than 1% in the adult tumor and less than 5% in the GU tumor. But still we see, especially in the referral center and institutes, we keep on seeing these patients. And this is a tumor which is neglected by most of the practicing urologists, general urologists. And of course, the residents, they do study about these tumors since MBBS days. But there are few areas where there are consensus, there are few areas where no consensus. Some areas like whether to go for a biopsy or the contralateral testis or not, but like whether you want to go for a partial orchidectomy or not, there's a few areas. And of course, whether the microRNA, what you are talking, whether it is going to be the gold standard or not. So there, I am sure those experts will they are going to deliberate all this. But there are one consensus, everybody will agree that there's no scope of screening for testicular tumor, isn't it? So rest people will deliberate, and I welcome the overseas faculty, Dr. Aditya. I didn't know much of you, but I heard from Gagan that your specialization in microRNA. I would love to hear from you. I had done few studies on microRNA, but not in testicular tumor, mainly for prostate cancer and bladder cancers in our institute. I'm from PJ Chandigarh. And Dr. Valentina, Italy, we have a special relationship. I don't know whether you know it or not. Our past President of Congress, Sonia Gandhi ji, she is from Italy. So welcome to India. And of course, all are our Indian faculty members. And I'm sure the deliberation today is going to help all the trainees as well as the young members and the all other members. And with this small introduction, I think we can just carry on other than wasting time. Thank you very much.
Thank you, sir.
Sorry, sir. Dr. Gagan, before you start, we'll just hear from ma'am. Sujata, ma'am, you're there? Ma'am, you have to unmute.
Yeah, I'm there very much, but I think we'll start with Dr. Gagan. I'll be there for the thanks.
Sure, ma'am. Thank you.
Sure. Yeah.
What
Thank
you,
you,
Gagan?
madam.
Over to you.
Yeah. I've used a specific term in the title of today's webinar, the unprecedented. And the reason for this is, as all of us know, that testicular cancer has a kind of survival of more than 90%, even when you see patients with advanced stage. And amongst us in the urology community, and I would say all across oncology, these kind of outcomes are not very often seen. And also, this is the cancer which would affect young men actually in their 20s and 30s. And I see that this becomes even if we are seeing these patients very rarely, even if we are seeing 5 patients in a year, it becomes our responsibility that to ensure that everything right that this patient has to receive in terms of the management is done, and the patient receives that more than 90% survival that these young men would deserve. And with this thought, I have conceived this program and tried and get the best people for each of the talks. And let's start with the first talk, which I would want to invite Dr. Valentina Tateo. And as I've just mentioned, she's a medical oncologist at the San Rafael University in Italy. And she probably is, the wisest person right now to talk about epidemiology and the global, and the concerns of increasing incidence of testicular cancer. Dr. Valentina, you can share your slides.
Thank you, Gagan, for the introduction. So, I will share my screen. Could you see my screen?
Yes.
Okay. So, the title of my presentation is Global Burden of Testicular Cancer. Is there a cancer? Yes, there is absolutely a cancer, and we are trying to understand why. Testicular germ cell tumors are rare tumors, but among genitourinary tumors are the most frequent. In 2022, the global age standardized rate of incidence for testis cancer was 1.7 per 100,000 person year, but significant worldwide disparities were observed. Testis cancer is the most frequent cancer in young men, especially in white men. And this has important implication by a psychological point of view, but also socioeconomical, since these tumors affect men during their most productive years. In the last decades, something is changing because we are observing an important changes in epidemiology. There is a global rise in incidence, but there is a rise in incidence also in historically low incidence regions. In this slide, we can see the huge differences that are present in incidence between our countries. In my country, Italy, the age standardized rate for incidence is of 9, while in India is just 0.57. So there is a huge difference. Indeed, Europe is the region with the highest incidence, followed by Northern America, Oceania, Latin America, and finally Asia and Africa are regions where testicular germ cell tumors are really rare tumors. There is a significant association with the Human Development Index. Countries with very high and high HDI are countries with the highest incidence. Here are the regions, the top 5 regions and the top 4 countries for incidence in 2022. Interestingly, with exception of Norway, that is a country with historically high incidence, the other 4 new entries in the top 5 countries for incidence are all countries from Eastern Europe, which is a region where historically the incidence was low. So the global incidence is rising, but in some regions there is a greatest increase, in particular in Japan, in Thailand, and in Korea. And the projection for the near future are of continued rise, in particular in Europe. By 2035, a further 32% increase in incidence is expected in Eastern Europe. Focusing on India, in 2022, the age standardized rate was of 0.57, so a low incidence, but by 2050, a 24% increase in incidence is expected. Also, inside India, there are disparities in incidence among different regions, with some regions in which a higher incidence was observed. Regarding the risk factor for testicular germ tumors, there are 3 principal groups of risk factor: the genetic predisposition, the prenatal perinatal risk factor, so the early life risk factor, and the postnatal adult life risk factor. The Mendelian inheritance plays just a minimal role in the inheritance of testis cancer, since only CHEK2 has emerged as a moderate penetrance genes associated with higher risk. However, the prevalence of this mutation in testis cancer is really low. Polygenic etiology, conversely, has an important role, is the principal factor involved in inheritance of testis cancer. 78 single nucleotide polymorphism have been observed to be associated with an increased risk of developing testis cancer, accounting for 44% of hereditability. This single nucleotide polymorphism regards genes involved in the germ cell development and chromosomal segregation, which are key points in the pathogenesis of these tumors. Moreover, familial clusters and the significant variations in incidence according to ethnicity reinforce the theory of an important contribution of genetic predisposition. Regarding other risk factors, the evidence is of lower quality, since data came from observational studies like cohort studies, case control studies. And these type of studies are characterized by a risk, an important risk of bias due to several uncontrolled confounding factors. Among the early life risk factor, the most important seems to be the in utero exposure to pesticides containing endocrine disruptive chemical, the maternal levels, hormonal level during pregnancy, but the most well established risk factor in the early life is cryptorchidism. Cryptorchidism is associated with a 4-fold increase in risk, in particular when orchidopexy is delayed. Regarding postnatal adult life risk factor, also in this case, the evidence is of low quality. The most significant seems to be infertility, tall stature, but also a diet with a high amount of salt and processed meat, an excess in alcohol consumption, marijuana use, or exposures to several chemicals, occupational exposure, for example, to PFAS, that are chemicals containing in firefighting foams, and so on. These are the results of a large meta-analysis on this topic. The stronger results from this meta-analysis are for prenatal early life risk factor, for which a significant 44% increase in testis cancer risk was observed. For the other risk factor, the results are less substantial and with a high heterogeneity, also after removal of risk factor of outliers. So early life risk factor seems to be the most important in the development of these tumors. Indeed, testicular germ cell cancer are due to a really complex interplay between a genetic predisposition and the exposure to an environment that interfere with the normal development of germ cell, the development during normally adolescence or early adulthood of the invasive tumor. Socioeconomic factors seems to have an important role since there is a high association with HDI, and probably the increase in also the historically low incident population is due to migration and socioeconomic changes in habits in the low incident population that increase the environmental exposure to unrecognized risk factor. It's really important to bridge the gap, the research gap on genomic data, since genomic-wide association studies are focused only on European ancestry, leaving other ethnic groups underrepresented. And considering the rising global of testis cancer burden, there is an urgent need to identify modifiable risk factor, improve early detection, and implement preventive measures for the high risk groups. So what can be done? It's important to strengthen prevention strategies, promote early detection, enhance the quality and completeness of cancer registry data, in particular in some regions of the world where cancer registry data are completely absent. Improve the design and rigor of epidemiological studies in order to obtain more high quality data. Ensure high oncological outcomes globally, including in developing countries. And this is a really important point, since also for mortality there are important disparities between low and high income countries. Minimize exposure to established risk factor, expand genomic research across underrepresented ethnic groups, develop tailored screening programs for individuals at high risk, and a lot of other action are needed for the moment. Thank you for the attention.
Thank you, Dr. Valentina. I think we'll reserve the questions, from the colleagues and the audience for the end. We'll go to the next talk, which would be given by Dr. Harshit Garg, who's a urologic oncologist in Delhi and a good friend. Dr. Harshit would be talking about the evolution of testicular cancer over the last 5 decades. What happened, what good things happened to have, let us achieve such a good outcome in this cancer.
Can you guys hear me?
Yes, Harshit.
Thank you, Dr. Gagan, Indian School of Urology, and all of you to give me this opportunity. It's a very interesting story, very unique topic, that how testicular cancer evolved. It also gave me an opportunity to learn and how the real science in oncology has evolved over past 5 decades. And I hope in next 10 minutes I'll not bore you. It is like a story I'll try to build up, and you all go on with this story with me, and enjoy the journey of how testicular cancer evolved. So quick disclosures, no major conflicts. I'm a uro-oncologist practicing. So the idea is what all we have achieved. So, in a summary. So in testicular cancer, we have now achieved, cure in about 95% of all patients. We have refined our surgical techniques. We have minimized the short-term and long-term toxicities of therapy. And now we'll take the journey of various drugs, which, FDA have approved from 1960s, to 1990s. So why this testicular cancer oncology? Why are we talking so much about this, journey, and how is it unique? Because, it serves as a prototype for the curable solid tumors. It is, groundbreaking in terms of use of serum tumor markers. And, once we learn this journey, we'll understand, how the various clinical trial designs and how various combination therapies in, oncology have developed over past decades. So this is sort of a timeline for the key discoveries. We start our journey from 1920s. We go till, of course, this diagram was till 2007, but we'll go on till 2020s, which is latest is miRNAs. So let us start our journey. So this was a journey when there was no chemotherapy. It was a pre-chemotherapy era in 1920s. What was the treatment at that time for testicular cancer? It was orchiectomy, and either you do RPLNDs or radiation. So seminomas, people gradually understood they were more radiation sensitive. So there was 95% cure in that with radiation. Non-seminomas, they were not very good responding to radiation, and surgery was there. So grossly, this was the management. And we don't have good CT scans, we don't have good imaging. So what we were doing was mainly surgical staging of these diseases. And then what changed, in early 1950s and all those areas, we had the HCG, and earlier it was urine detection, then we have serum detection, which was a tumor marker. Then we developed AFP, and then we developed these markers and imaging, which gradually evolved to ultrasonography and CT scan, which reduced the need for surgical staging. But what was happening before, before chemotherapy came in, one of the first agents which was used as a chemotoxin or chemotherapy agent was actinomycin D, and it showed a good response in Wills tumor. And so it was used in testicular cancer. And this was the early series on Dr. Lee from MSKCC, which showed, actinomycin can do actually 10 to 20% remission and 5% cure. And they did, some papers early in 1950s where they tried to combine actinomycin D with other agents. But it did not do great, but we had some potential with actinomycin D. And then came, this landmark paper, which we talk is, which was published in NEJM in, 1958, where a choriocarcinoma and trophoblastic tumor was treated with, a purine antagonist. And what we are talking is methotrexate. So this was a time when methotrexate came in. It was 1958, and it showed, complete response. One patient was treated completely with this methotrexate. And then the idea came in with the MSKCC guys, and they tried to combine methotrexate with actinomycin D and chlorambucil, and they showed their results with effects of combined drug therapy for the first time in metastatic cancer of the testes. And we are still in 1960s at that time. But drugs were happening, and this was very commonly called Indian flower called Sadabahar, Vinca rosea. You will find it almost at in every other garden. And this was sort of a wonder drug because when this particular chemical vinblastine was extracted from this flower, the response was tremendous. And 32 patients, this paper is particular from MD Anderson, when Samuel and Hu from Houston MD Anderson, they tried to use this in testicular tumor and showed a great response. And we were having vinblastine, we were having actinomycin, we were having chlorambucil, but then something happened. Something happened with this professor from University of Michigan, Dr. Barrett Rosenberg. In Michigan, he was working on E. coli cells growth and something with ammonium chloride agar and platinum electrodes. And what he found that that this particular platinum chemical was able to inhibit the cell division of E. coli, and that was extrapolated for the cancer growth. And this was the paper which got published from Roswell Park, where they showed that this platinum has a great potential in treating testicular tumor. And even when actinomycin D failed, 9 of the 11 patients, they were tremendous response with platinum based therapy. And problem was kidney toxicity, nausea and vomiting, and so that was a limiting factor. And so further, this paper is particularly from the Indiana, where they use the combination of cisplatin, vinblastine, and bleomycin. So we are trying to go from monotherapy towards the combination therapy gradually. We have started from 1960s. We are in 1970s now, and they gave this particular regime, which was standard of care at that time. 4 cycles of cisplatin, vinblastine, and bleomycin, and they also continued with maintenance vinblastine. And what would they do? That if person nodes are there, then they would do RPLND. So 33 out of 47 patients, a good number, complete remission. 5-year overall survival, 64%. So this was some one of the landmark papers, or a landmark event in the management of testicular cancer in 1977 when they had this PVB. And so this was the first time, or very unique times when FDA approved cisplatin without even RCT, because the results were so great with the use of cisplatin. But the problem remained was a toxicity, the neuromuscular toxicity and a myelosuppressive toxicity, especially with the cisplatin. And so then, there were a lot of papers, early 1980s, where they tried to, use a chemotherapy combination in the testicular cancer, and they compared various regimes. The essence was, ultimately PVB4 became the standard of care in 1980s. Unless we have this particular chemical, which was etoposide. Etoposide is basically a derived from podophyllin toxin. And, I think Dr. Aditya would know this, a mayapple was, one of the fruits there, very common in states. And, the dried roots, it was extracted from this toxin. And, etoposide is an analog from this, and it was working great. And first it was tried in second line therapy when platinum was failing, or actinomycin or vinblastine were failing. Then etoposide was being tried. And this was, the study of Southeastern Cancer Study Group, and what they found that when they were using this particular cisplatin with etoposide, 43 patients achieved complete remission and 23% remained disease free. And so the first time in relapsed solid tumors, a second line chemo worked. And this is, we are talking 1980s. When the first line chemo has failed in solid tumors, there is some potential that second line chemo is working. And then, at the same time, similar times, MSKCC was experimenting with their, VAP6 regime. We're trying to do everything, cisplatin, vinblastine, bleomycin, cyclophosphamide, actinomycin D. And, they were able to publish and show that when you use this regimen compared to etoposide with cisplatin, I'm sorry, so that is superior sort of thing, and they had these prognostic factors LDG, SCG, and so EP became the standard of care after this particular paper from MSKCC. And then Indiana University also started studying cisplatin, bleomycin, vinblastine, etoposide, and what they found was BEP became the standard of care. So, from EP, we evolved to BEP, with this paper from Indiana University. And so, from 1974 to 80s, gradually, we are trying to substitute etoposide for vinblastine. And we were successful. There were two big studies, EORTC study and SCG study. So basically, when you substitute etoposide from vinblastine for all of us, it decreases toxicity, it increases efficacy, and it shortens the duration of therapy. So overall, you actually have replaced etoposide everywhere, and vinblastine was no longer being used. And so this was the era in 1980s when we have reached, BEP, replacing the vinblastine in the, management of the testicular tumor. But, something else was there. The problem was, cisplatin, the vomiting, 10, people used to have average 10 episodes of vomiting after a single shot of, cisplatin. And this was all resolved when, GlaxoSmithKline, they were working on this drug, particularly, 5-HT3 antagonist, which, comes like name, the ondansetron. We all have heard of it. It's called MSET very commonly in India per se. And so it decreased the vomiting episode, increased the tolerance, improved, remarkably the results of chemotherapy in testicular tumor. And the second was, which is a very unique thing, the collaborative consensus, international germ cell consensus classification established, the definitions were established, and we all know IGCC classification now, which is based on primary tumor site, metastatic site, and tumor marker levels, which, goes as good, intermediate, and poor. And so, with this in 1997, we are having, BEP as a standard of care. And, we have this classification, we have ondansetron with us. But, bleomycin was permanently toxic. So we were trying to see, whether we can skip bleomycin. But, there are a lot of trials happened in early 1990s. And when bleomycin was being skipped, the results were inferior. So bleomycin became indispensable, in the treatment part. Then, another substitute for cisplatin versus carboplatin. Can carboplatin, because, it was, less toxic, but all the trials show that it's inferior. And so, you can't really replace carboplatin with cisplatin in, patients. So, we had something for good risk, but poor risk, we are still struggling. And so, what we effectively had BOP4 as a standard of treatment, but it still had, 50% response at those times. And so there were a lot of papers which tried to intensify the regime for poor risk, either use double the dose of cisplatin. There are various trial groups, so as just summarized in some boxes. Either you added paclitaxel, you added, tried VIP, you tried high dose chemo, you tried VIP1 with high dose VIP. But, all of them, showed a BEP4 is okay, fine, other regime essentially doesn't work. And so what next was, some trying to find a management of relapse cancer. And then came the concept of high-dose chemotherapy. Basically, we are giving high dose of carboplatin etoposide. The more important thing was, we are using carboplatin and not cisplatin because of the severe toxicity. Carboplatin mainly has, bone marrow suppression, which we were able to evade with the bone marrow rescue, especially in 1995 when we started having peripheral blood cells, stem cell transplantation. So we were able to rescue that. And this was the paper published in NEJM again from Indiana, where they were trying to use high dose chemo with, peripheral blood cell stem cell transplant rescue. And they were able to show a 63% complete remission for those patients who have progressed after first line cisplatin, which was actually remarkable. And even, even second line or third line, this therapy was working. And then similar group was working from MSKCC. They tried to, modify their regime. They added paclitaxel ifosfamide with induction chemo and stem cell mobilization with high dose, chemotherapy. And they also achieved, 50% complete response. So there was things happening, high dose chemotherapy. And, so we all know about high dose chemotherapy today, but we are also worried. I think Dr. Amit Joshi will talk about this. So I'll just, touch briefly on that. Long-term toxicity of cancer survivors, we are having a trouble with secondary leukemia, metabolic syndrome, cardiovascular disease, infertility, neuronephropulmonary toxicity, hypogonadism, behavioral issues. So, all this was around the chemotherapy. And since I just had 10 minutes, so I'll just touch briefly on, two more important recent, things. One was, nerve sparing and template dissections, which, of course, came in predominantly from the Indiana University and then, MSKCC. And we all know that, preservation of sympathetic nerves by exclusion or from, identification is important for preserving ejaculation. We had modified templates. We do nerve sparing in early stage diseases. Of course, we have now robotic surgery, coming into, in robotic RPLND as well. And then, this is the latest, in the armamentarium for the manifested cancer is the miRNA. In 2000, we have so many papers, and we have Dr., none other than Dr. Bagrodia to talk about this. So, the Ascens is one of his, this is one from one of his urology times, which I have taken, that miRNA 371 has, highest sensitivity and specificity compared to traditional markers. It can help in early relapse detection and predicting clinical outcomes. We are still having a challenge to differentiate viable tumor from necrosis and teratomas. Assay standardization and validation is very important. And of course, we are all working towards, great clinical trials to, how to optimize and use these assays. And I think Dr. Aditya will talk more on this. So, in summary, there are certain, persisting issues. We need more effective treatments for poor risk disease, relapse disease, relapse. And a comprehensive multidisciplinary tumor approach is a very important or key in management of testicular tumors. Take home messages, each discovery in this, journey of testicular tumor preceded the previous discovery. RCTs have been used immensely to minimize toxicity and maximize efficacy. The testicular tumor stands, for a rational use of a combination therapy, how it was established. We all have refined our surgical techniques. There have been advancement in radiation. And so what is so unique about testicular tumor is a very unique integration of medical oncology, radiation oncology, and refined advanced surgery. And, with this, thank you. And, we'll be happy to take any questions initially or later on, as per Dr. Gagan Prakash discretion. Thank you so much, sir.
Yeah, thank you, Harshit. So I think we'll go to the next talk, which would be taken by my colleague, Dr. Amandeep Arora, who's also at Tata. And Aman would be talking on management of early stage, that is stage 1 and 2 germ cell tumors today in 2025.
Right. Good evening, everyone. I think my slides are seen and I can be heard well.
Yes, Aman.
Okay. So I'll proceed to my talk. It's about managing early germ cell tumor, that is stage 1 and stage 2. So this is what we're talking about, stage 1 and stage 2. When we talk about stage 1 germ cell tumor, it means cancer limited to the testis. It is divided into stage 1A and 1B with not too great implications. There is stage 1S in non-seminomatous germ cell tumors, where we have taken out the disease. There is no more disease on imaging, but there are raised markers. You have stage 2 disease. Stage 2 disease means the disease is beyond the testis alone and is now also in the nodes. And you have N1, N2, N3 depending upon the size of the nodes. And also you could have S1 markers. Coming to management of stage 1 disease first. Stage 1 seminoma. So stage 1, so the disease is only in the testis. Our imaging does not show anything else. But 10 to 15% of these patients could have occult mets. So they have micromets, but you're not seeing them. And that is why you would probably consider treating them. Now, further options include either keeping them only on surveillance and watch for the relapse to happen, or give them adjuvant RT or adjuvant chemotherapy, thinking that they might have micromets. Now, this decision is based on the patient's risk status and compliance with follow-up, and is obviously a shared decision process with the patient. Now, what risk status, what risk factors do we look at? For seminoma stage 1, we look at tumor size more than 4 centimeters and whether there is invasion of the retinal on the pathology specimen. So first option is surveillance. So the rationale for surveillance, as I told you, only 10 to 15% have occult mets. So the RFS is 85% at 10 years, which means that 85 of them would not have relapse of disease. With no high risk features, the recurrence rate drops to just 6%, and the cancer specific survival, even if you have to treat relapses later, is not affected. And that is why surveillance is a very sound strategy. So what is the protocol? We do physical examination and CT scans at 3 months, and then 6 monthly till 3 years, and then annually. Tumor markers for seminoma in follow-up are optional, and the chest imaging is also as indicated. The advantage of surveillance is there is no toxicity because you're not giving adjuvant chemo and radiation. The disadvantage is that the patient needs repeated CT scans, radiation exposure, and cost. And definitely the patient should be compliant with strict follow-up. Now, as I told you, one disadvantage is that there is repeated scans that we are doing. This is one trial, a non-inferiority trial, which was reported in JCO just a few years back. 669 patients of stage 1 seminoma, that is a lot of patients, 4 arms. Arm 1 was 7 CT scans as we do right now. Arm 2 was they replaced CT scans with MRIs to reduce radiation therapy. Arms 3 and 4 also had CTs and MRIs, but at much lesser frequency. So instead of 6 or 7 scans in 5 years, we were doing only 3 scans. And the final conclusion of this trial was that reducing the frequency of imaging and using MRI over CT did not impact outcomes. So this trial has actually overcome the disadvantages of the surveillance strategy for stage 1 seminoma. What about chemotherapy for stage 1 seminoma? So the chemo that we used is single agent carboplatin chemotherapy. We use 1 or 2 cycles, most commonly 1 cycle. This is how the dose is calculated. There is a GFR element in calculating the dose, and this GFR is determined by the DTPS scan, and it's not your estimated GFR. 5-year disease-free survival is in excess of 95%, which is excellent. Follow-up after chemotherapy is done by annual scans, so it is much less frequent than what we do for surveillance alone. There is no significant long-term toxicity when you use only. What about radiation therapy for stage 1 seminoma? So we give radiation therapy to the ipsilateral retroperitoneum. This is the dose that we give. The long-term RFS is as good as chemotherapy, but long-term toxicity is a concern. And that is why radiation therapy for stage 1 seminoma is mostly avoided. So we do a risk-adapted approach. For somebody with no risk factors or maybe 1 risk factor, surveillance is the treatment of choice. And if somebody has 2 risk factors, we would probably give 1 cycle of carboplatin. Now that was about seminoma. We come to stage 1 non-seminoma, which means that you've done the orchidectomy, there is no more disease on the scan, and your markers have come down to normal. In this, there can be occult mets in 25 to 30% of patients, so this number is actually double of what it was in seminoma. These are the high-risk features that we take into account: presence of LVI and predominance of embryonal component. And LVI is the more important, or rather probably the single most important risk factor in the orchidectomy specimen. What are the options available in non-seminoma? We have surveillance, adjuvant chemotherapy like seminoma. And the third option here, radiation therapy is replaced by RPLND. Why? Because one component of non-seminoma can be mature teratoma, and mature teratoma is radiosensitive. Now, how do we do surveillance for stage 1 NSCCT? Again, the rationale is that most of the patients are not going to have a relapse. So if you treat all, you're probably over-treating, and that is why you would treat only those who go on to have a relapse. And even if you do have a relapse and then you treat the patients, the overall survival is not compromised. What is the disadvantage? The disadvantage is that the relapse rate is around 40% if the patient has high-risk features or if the patient has LVI. Cost and radiation exposure of repeated CT scans. So that TRIST trial that we spoke of had only seminoma patients. So I'm not sure if those findings can be extrapolated to stage 1 non-seminoma patients. So we still end up doing a lot of scans if we put our stage 1 non-seminoma patients on surveillance. And obviously the patient needs a high compliance. That is the schedule. It is more intensive in years 1 and 2. tumor markers play an important role, unlike in seminoma, and then we phase out, by years 3, 4, 5. What about BEP is given as compared with single cycle of carboplatin in seminoma? The relapse-free rate is again excellent because you're treating micromets, and 1 BEP is as effective as 2 BEP, and hence we use 1 BEP. And there has been a trial which has compared 1 BEP with RPLND, and obviously the RFS is better with BEP because BEP is systemic therapy and RPLND is local therapy. There is no significant long-term toxicity is what is written, but the toxicity gets added on, when you have 3 or 4 cycles being given to metastatic GCT. So if you have non-seminoma stage 1 with high risk features, that is LVI, the preferred treatment option would be 1 cycle of BEP. What about RPLND for stage 1 non-seminoma? So nerve sparing RPLND can be done at centers of excellence. The relapse rate is definitely higher than using chemotherapy because you're doing only local therapy, and then these patients can relapse at distant sites in the body. And then if they do relapse, these patients are then going to be called metastatic germ cell tumor, and they would then need 3 cycles of BEP. So the disadvantage is that those who do relapse need more chemotherapy than what they would have got if they were given only 1 cycle of chemotherapy. The advantage is that we don't give chemotherapy to all patients and give that only to those who deserve it. And the further management is according to the pathology report. So you will be preferring RPLND over chemotherapy if your specimen of the orchidectomy had a lot of teratoma component, because teratoma is radio-resistant and also chemo-resistant. And this is how the template would look for a primary nerve-sparing RPLND with those nerves spared. And the further management after a primary RPLND would depend upon whether the patient remains a pathological stage 1 patient or has been upgraded to a pathological stage 2 patient, and then we would give 1 or 2 more cycles of chemotherapy. So this is one chart which I've picked up from the recent European guidelines. And if you look at the left side of the chart, low risk, which means no LVI, and the standard option is surveillance. If you have to choose against surveillance, you would give 1 cycle of chemotherapy. And if the patient cannot get chemotherapy, you would do RPLND. On the right side, if the patient does have LVI, your standard option is chemotherapy. And if you cannot give chemotherapy, you would then give RPLND or surveillance. So high risk factors, which is LVI, choose chemotherapy over surveillance. Quickly ending with stage 2 disease. So stage 2 means the disease is beyond the testis and is in the nodes. So we have stage 2 disease. Stage 2 and AB is what I'm going to talk about, which is nodes up to 5 centimeters. Because stage 2C, which is nodes more than 5 centimeters, is managed as we would manage stage 3 germ cell tumors. So when we have stage 2 and A and B seminoma, when you have on the left side of the chart stage 2A, which means that a nodal disease in the retroperitoneum on the CT scan is less than 2 centimeters, you can either choose radiation therapy or chemotherapy. If you then have stage 2B disease, which means the node is 2 to 5 centimeters in size, they write chemotherapy first and then write radiation therapy, because you're dealing with a bulkier disease. Probably you need more systemic therapy. Now we're talking about de-escalating treatment. So RPLND for stage 2 seminoma. So we are having a cancer webinar, and we're talking about reducing treatment, right? This is what Harshit was saying. We've reached a level in treating germ cell tumors where we are probably thinking we are doing too much and we should probably take a step down. So as I told you, seminoma is probably not done too much for, RPLND is probably not done too much for seminomas. We don't do post-chemo RPLND for seminomas because of desmoplastic reaction and bad planes. But when you have not given chemotherapy for seminoma, RPLND can possibly be done. You have 4 single center phase 2 trials, and the recurrence rates are between 5 to 30%. The advantage is that when you do RPLND, you actually find out whether the patient has nodal mets or not, because some nodes on the CT scan can turn out to be reactive nodes, and the patient gets downstaged from a stage 2 disease to a stage 1 disease. And if you prove that the patient has nodal mets, that is the patient to whom you give chemotherapy. So it's personalized care. The disadvantage is that you could have retrograde ejaculation even if you do bilateral nerve sparing surgery, and definitely it needs centers of expertise. So that 1 or 2 cycles of chemotherapy could be given by any medical oncologist anywhere in the world, but a primary nerve sparing RPLND can not be done in many centers of the world. So it needs expertise. Again, we gave chemo and radiation therapy for stage 1 seminoma and also stage 2 seminoma. Can we come down? Because we were giving 3 cycles of BEP for stage 2A and B seminoma. It is the same cycles of BEP, 3 cycles that we would give even for somebody who has a 10 centimeter node. So can we come down for somebody who has a smallish node? So what we can do is combine chemo and RT. So we give RT only to the enlarged node and not to the entire template. So that brings down the toxicity of RT. And then we give only one cycle of carboplatin for the micrometastatic disease in the body. Do not give BEP and reduce the toxicity, and do not give 3 cycles. So this is much lesser treatment, and this has shown to have almost similar recurrence-free survivals compared to giving 3 cycles of BEP. The other strategy could be that you use an FDG PET CT after giving 2 cycles of EP and then decide based on the avidity on the scan whether you want to give more chemotherapy or not. Last one slide for stage 1S and stage 2A and B NSGCT. What is stage 1S? There is no disease on the scan. You've done the orchidectomy, but your markers are not coming down to normal. So there is some metastatic disease somewhere which is producing the markers, but your scan is not showing it. And stage 2 and A and B means there are nodes seen on the scan. So for stage 1S, we would keep repeating markers more often and see whether they go down or not. We might want to repeat a scan again to see if the nodes now enlarge and can be seen. And we would also want to rule out contralateral testicular tumor before taking a decision. Once we have confirmed that this is stage 1S, there is something happening in the patient. And also for all patients who have 2 to 5 centimeter nodes on the scan, we give 3 cycles of BEP or 4 cycles of EP. Now, if you have stage 2A with S0 markers, it means there is a node seen on the scan, but your markers are normal. This is opposite to stage 1S. On stage 2A with S0, you have node on the scan, but no markers. You can probably hold on, wait, repeat the scan in 4 to 6 weeks to see if the node goes down. If there is regression on the scan, you do surveillance, which is justified now. If there is stable disease, it means the node is not going down. You probably do a nerve sparing RPLND, take the node out, see the pathology. If it's a pure teratoma, that is the end of the treatment for the patient. If it does show some viable malignancy which was not producing markers, you can probably give 1 or 2 cycles of adjuvant chemotherapy to the patient. So nerve sparing RPLND is preferred treatment for stage 2 NSGCT without a rise in tumor markers. Okay, so we probably don't even have time for a summary slide. Thank you so much.
Thanks, Aman. Crisp as always. I think if Harshit's was a history class, then yours was a mathematics class. Thank you. Now there's a wake-up call for all the surgeons. We are going to have a lot of surgical pictures and videos. So we are talking about the quest for R0. So R0 is a resection where there is microscopically no disease confirmed. And in the spectrum of RPLNDs, we could have, RPLND required for a very, very early disease where the functional outcomes become more important. And at the other end of the spectrum, we can have really, really bulky disease going across, all the vessels. So for this, we've got 2 really, really popular surgeons from our country. One, Dr. Anand Raja, who would be taking the first talk, which would be on bulky disease, how to manage and tackle these bulky disease, to what extent you have to go to ensure that you have an R0 resection. Over to you, Anand.
I think my slide is seen and I'm heard.
Yes,
I'm
Anand.
seen and I'm heard. Yeah.
Yes, Anand. Yeah.
So before, thanks to the organizers, thanks to Gagan, thanks to the USI for calling me here. As usual, I'm always grateful to all my teachers, especially both of them who've taught me everything that I know about RPLND, Dr. Satish and Dr. Kadresan. So again, important here is this is how an RPLND should look like. This is slightly more. You have infrahilar disease. You also have suprahilar disease, but you have extensive disease here. You can probably see a couple of things here. The entire retroperitoneum is out. The renal vessels are there. There you can see that the right side renal artery, the multiple vascular abnormalities can be there. So it's a precaval renal artery that's going there. What you can also see going above is that because the patient also had suprahilar nodes, you can see the SMA that is going right there. And you can also see the celiac trunk. And if you look a little more closely, you can probably see the bifurcation and of the celiac axis into the splenic and the hepatic arteries. So and you can also see the crus of the diaphragm on the right side and the crus of the diaphragm, which has been resected on the left side. So you can't see there. So that's the crus of the diaphragm on the right side. So this is an extensive RPLND. Now we have to see whether this is worth it or not. And why is it that we need to do these kind of surgeries here? So there are multiple challenges when we do these RPLNDs. The patient, the build of the patient, general condition, the surgeon's expertise. But what we'll be focusing on are these 3 things here. Technology is something that Amitabh will talk to you about, robotic, laparoscopic RPLND. But what we will talk about is the anatomy, the extent of the disease, the fibrosis therein, and the vascular problems that we encounter and how is it that we overcome them. I'm sorry. Yeah. So you have to be very, very careful. The first thing that I have been taught when you do RPLND is to look at the vessels. You can have multiple vascular abnormalities. If you've not identified it pre-op, it's a disaster that is waiting to happen. You can see here a retroaortic renal vein. This is usually a very common entity. What usually happens here is that the damn node comes and gets stuck only on the vein here. Again, important to remember here that whenever you get this retroaortic renal vein, it is never at the same place as the right renal vein. It usually originates much below, probably just a little bit above the bifurcation, above the union of both the common iliac veins, and it kind of goes obliquely upwards and then goes into the kidney, and then it may also have aberrant branching there, which you can injure. So be very, very careful of these things here. We know that the one of the borders of the renal vein of the RPLND, you can have these double IVCs here. If you've not identified it, I mean, you can injure it here. So be very careful. Identify these multiple IVCs. One of the borders of the retroperitoneal lymphadenectomy is the ureter. If you've not looked at the delayed phase, so what we tell everyone is look at the arterial phase, venous phase, and the delayed phase. If you've not looked at the delayed phase, you'll have these double ureters, and if you're not identified that, you might end up injuring one of them. Again, one more example of the retroaortic renal vein. So these are the vascular, anatomical differences that can be there, which you need to identify pre-op. You might have a lot of problems because of local extent of disease. So what we see here, you see the aorta, you see it completely encased. You don't know where is the IVC. You probably can't see it. You might think that you might end up wanting to resect the aorta. But if you look a little more carefully, the aorta is not of consequence too much here. What you see here is in this bottom right picture on the right side, the left side psoas major is completely free. As you can see here, the entire tumor mass, nodal mass, is infiltrating into the left side psoas muscle. So this is what we ended up doing. So although the aorta was encased, the picture on the right side, as you can see, we've managed to pretty much isolate the IVC, the aorta, everything else. But important here is that the image on the left side, you can see that the aorta is there, the left common iliac artery is there, but then the entire psoas muscle where the nodal mass was infiltrating has actually been resected. What you can see there is the vertebra, and in between what you can see is the intervertebral disc. So such extensive local extent can be there, which needs to be resected. If it has to be done, it has to be done. And the reason we do it has been told by the previous authors, because the excellent survival is there. Sometimes you might have this we spoke about the suprahilar disease, but sometimes you may also have suprahilar and retrocrural disease that is going into the lower chest. Again, is it worthwhile? You can see here, this is the pre-chemo images where you can see that the disease is going right in the mediastinum, lower mediastinum, up to the inferior pulmonary vein. You can see here that the disease is on both sides. It's there on the left side, it's there on the right side. It's going right through the through the esophageal hiatus also. So this is what you see when you open. Again, we were very thankful that we got all these cases building one on top of each other. If I had got this case very early in my career, I'd probably have given up. But thankfully, we got these cases as graded difficulties. As we went ahead, we got more and more difficult cases. So when you open here, you see that the renal vein is kind of been completely encased. We had to do a nephrectomy here. Again, a major psoas resection has been done along with the nephrectomy. You can see that the vertebra has been removed. But again, importantly, what you can see here is the right crus of the diaphragm. This is an anatomy that a lot of people are usually not very familiar with. You might require the help of an upper GI surgeon, but it is good that you familiarize yourself with the anatomy, because if you can operate on these cases by yourself, nothing like it, because they probably won't know the extent of disease and they might be very scared to operate on the aorta and the IVC as much as you do. So this is what we see here. You can see the right crus of diaphragm, the left crus of diaphragm. If you can see there, that's the nodal disease, which is in the retrocrural area. An artist's impression of how it looks like. And we have actually gone and divided. We've separated the esophagus. We can see the retrocrural mass, and then we've gone ahead and completely removed it. There is also the little bit of tumor between the aorta and the IVC. the retrocrural post-resection bed that you can see. But doing such kind of dissections comes with its own sets of problem. As you can see, this patient had a lot of pulmonary infiltrates, lung infiltrates. He was there with us for about a month for lung toxicities, made a recovery, and then went on. So long surgeries, big surgeries, be prepared for complication, but totally worth it because the survival is so good. Sometimes you also encounter these kind of conditions. You have the horseshoe kidney here. Unlike a normal RPLND where the kidney is on either side and you can see the field very clearly, the para-aortic, the paracaval, everything else you can see very clearly. If you see the image on the right, to the right side of the screen, you can see that the aorta is there and the IVC is there. But because the horseshoe kidney is there, they are kind of fused in the middle. The ureter comes on top, more towards the central. So this part of the cava and the aorta that is covered by the horseshoe kidney is really very obscured. So you have to lift up, you have to mobilize the kidney on all sides, make sure that you get the vascularity of the kidney, make sure you loop both sides, renal arteries, veins, and then you don't end up injuring any of them. You have to mobilize it on from the left side, right side, go up, go down, and then you have to do an RPLD. A little bit difficult, but if you have patience and you take adequate time and care, it all comes out. This is an artist's impression of how you can see it because it overlays it and overhangs it. The surgery here becomes a little bit difficult. Vascular involvement is again a very big problem. Usually what happens is that the tumor usually invades a small branch of the vein, grows inside the vein, grows into the branches, and then goes into the IVC. Sometimes, if you're fortunate, it'll be a floating thrombus. Sometimes it grows along the wall with direct venous invasion, where it may require vascular resection. So this was one of our very first cases that we did. As you can see here, there's the IVC here, which is infiltrating, invading the wall of the IVC. You had to do quite a lot of extensive resection. If you can see on the tumor on the right side, the post-resection bed, the IVC is completely resected and replaced by tumor. We had to put in an IVC graft to restore continuity. Sometimes it's not just the IVC. If it's the IVC, you're usually a little bit easier. Sometimes what ends up happening is that you might end up involving both the aorta as well as the IVC. When the aorta is also completely encased, it's infiltrated, and you may have to resect and replace both the aorta and the IVC. As you can see here, the aorta above, branches of the aorta below, the IVC above and below, everything in the retroperitoneum has been taken out, and we had to replace both the aorta and an IVC and an aorta graft. Again, one more, a very different case here. An extensive tumor, more on the right side. We had to take off the right side kidney. But if you can see here, we had to replace the IVC, and the left renal vein, as you can see, goes into the graft. Again, these kind of surgeries are a little bit more complicated because the graft is there. The graft has a propensity for thrombosis. If the thrombus extends into the left renal vein, you might land up in a little bit of a problem, but the patient is on long-term anticoagulation. It's about a year and a half, and the patient is doing quite well. Sometimes very early in my career, when I saw all these IVC graft and thrombus, I felt that it was probably better to put in an IVC filter. But then once I encountered this problem, as you can see here, the metal tip, the prongs of the IVC filter came out. It went in and got lodged into the anterior longitudinal ligament. It just won't budge, and all the nodal masses were there, and I couldn't mobilize the IVC at all without tearing it. So again, difficult scenarios. Here is a tumor that is both vascular as well as extent. Again, a tumor here, as you can see, there is the IVC. That's the tumor that's completely encasing the IVC. But there is vascular invasion of the wall. But as you can see, as you go up, there is also a small bit of tumor that is floating. That's the retrohepatic IVC, and that's the intracardiac IVC. There's a thrombus that's going all the way inside. This is what the intraoperatively it looked like. That's the tumor that's invading the IVC. That's the esophageal Doppler that is there, and there's a thrombus there inside the heart. And what we had to do was we had to put the patient on a bypass and then remove this thrombus. And we had to remove the thrombus and as well as to resect the IVC, replace it. And as you can see, the heart is now free. That's the tumor in the IVC with the long intracardiac thrombus that was there. Again, as told by the speakers before me, this is a little bit different from what you usually see. Again, very, very aggressive treatment is required for these testicular cancers because the survival is so good that no surgery is not worth the effort. Again, a tumor here, as you can see, is probably involving the vertebra. So we had to go and do a vertebrectomy. You can see the the stabilization screws here for the cervical spine. So there are multiple challenges. There are challenges of pre-op optimization, renal function, retrograde ejaculation, major surgery. Desperation RPLND is a problem by itself. Patient's nutrition, sarcopenia is a problem. The entire it's not just enough that you operate well. You should have a good team around you that can take care of the patient in the post-operative period. And the surgery, the preparation for the surgery just starts prior to surgery. So the take-home message is RPLND is a major effort. The effort is worth it as the survival is excellent. All attempts should be done to render the patient disease-free. Meticulous, careful dissection and patience is of paramount importance. There is no inoperable RPLND. On a completely different, hilarious note, I leave you with this WhatsApp message that I was talking to Dr. Satishan, was one of the first images that you saw. So this was a very difficult RPLND. And then he said, Anand, the surgery went on well, resected, preserved all the numbers, the ureters appears fine, about 4 liters of blood loss, but it's fine. The kidneys look fine. There is retrocrural extension into the intrathoracic part of the patient, but it looks fine. The intrathoracic portion has been resected. Plenty of IVC repairs, renal vein injury, renal vein repair, aortic injury, aortic repair. The lesion was better on the IVC, but stuck to the aorta. Everything is being removed. The right adrenal is resected, and everything else is fine. Started at 9 o'clock at 11 o'clock in the morning, finished at 8:30, and the patient is also fine. So there are multiple challenges, and to be very honest, there are no inoperable RPLNDs if you have enough time, patience, and meticulous work. I deeply acknowledge my teachers, my students, and all the faculty in the department without whom nothing of this work would have been possible. Thank you so much.
Brilliant, Anand. I think we'll now shift to from the maximally invasive to the minimally invasive talk. And I would like to call Dr. Amitabh Singh, another dear friend and uro-oncologist from Rajiv Gandhi Cancer Institute at New Delhi. Amitabh, you need to unmute yourself.
Now you can see me, sir. Can you hear me?
Yes, yes.
Can you see my screen also?
Yes, please go ahead.
Okay. So good evening, everyone. So I thought the Anand's talk should have been after me because he has a lot of pictures with large bulky nodal disease with like resection of multiple organs also with vascular reconstruction. So mine actually video is very different for him. So my video is just about very minimal burden disease where we can preserve the nerves also. So I'll just show very delicate anatomy of the post-ganglionic sympathetic fiber behind the great vessels. And I will just go into the steps, how I preserve them and how I do robotic RPLND. So I don't see that there is now role of any laparoscopic RPLND. There are only few surgeons who are doing laparoscopic RPLND because it is being just a diagnostic role. If we are having a therapeutic role as well as diagnostic, then robotic RPLND is now a gold standard for minimal invasive RPLNDs. And across the world now, this Da Vinci is being used. I think in near future, most of others robotic platform will be also used. So what are the ideal cases? So there should be low volume disease, minimal desmoplastic reaction. What are the steps for robotic RPLND? They are pretty standard steps which we are following into the open RPLND, from starting incising the root of a small bowel mesentery to lifting IVC and taking all the nerves and this thing. So this patient was basically a 24-year-old male, was diagnosed with right testicular mass, underwent high inguinal orchidectomy, and histopathology was mixed germ cell tumor. A combination of seminoma, embryonal cell carcinoma, pre-orchidectomy markers were high. He had a high AFP, beta SCG was high. But after 1 month post-orchidectomy markers were within normal range. So CT of abdomen showed almost 3.3 centimeter lymph nodal mass You can see in this CT scan, this is the mass which is situated at the interaortocaval groove. So this patient had a stage 2B disease. So I gave him option for the chemotherapy as well as robotic RPLND also. So patient didn't want to get the chemotherapy. He opted for robotic RPLND. So I planned him for robotic RPLND, primary RPLND. So I usually use Da Vinci Xi for robotic RPLND at our center because it gives us flexibility of the docking. So I always dock robotic this Da Vinci Xi from the side of the patient, because now what happens, the rest of the patient side, they are empty, they are vacant. So you can move around, or if you need any assistant, then you can bring your assistant from anywhere across the patient. And I keep the patient into Trendelenburg position and slightly right-sided tilt, so that all the small bowel, they go up to the right side of upper abdomen. So it opens retroperitoneum by default. I keep the ports between the umbilicus and pubic symphysis, and I keep all the ports in a straight line, although there are some different configuration of port placement also. And I put 2 assistant port, one 5 mm port and one 12 mm port to put the suction and hemolock clip. Rest, the steps start from the incising the peritoneum at the root of a small bowel mesentery, and this dissection is being continued for the duodenum mobilization also. Once duodenum is mobilized, this plane of dissection is continued laterally on the both sides to see the ureters. You could see this lymph nodal mass also into the interaortocaval groove. This is the right side ureter, which you can see. And the proximal margin of this field is the renal hilum. You can see all these renal vessels. So once the mobilization is done on the right side, I always prefer to take this curtain stitch on the right, incised peritoneum at the root of a small bowel mesentery. So I take just Vicryl and take to the anterior abdominal wall peritoneum, and I hitch with the hemolock clip. So there are actually technique where surgeon take the suture through the anterior abdominal wall outside also. So once right side is done, I go on the left side. I incise the root of mesentery of this sigmoid colon, and just separating all these pre-aortic and para-aortic lymph nodal packet. Same, the field is same. Upper boundary is renal vessels, left renal vessels, and the lateral boundary is left ureter. Same, curtain stitch on the both side. So once the curtain stitch is being taken, I confirm the boundary of the dissection, the lateral boundary, the upper boundary, the lower boundary. So I always start with just taking out the main lymph nodal packet, because once you take out this main lymph node packet, it opens up your retroperitoneum. It helps in identifying the great vessels, IVC and aorta, and you get to know where is the margins, where are the lateral borders of these great vessels. So now just I am taking out this lymph nodal mass, which is situated, which was situated at this interaortocaval groove. Because he had a right testicular tumor, so I had to take this gonadal vein anyhow. So just I am cutting this gonadal vein and mobilizing it as far as I can do in the supine position. So just for the information, I am doing all the supine RPLND right now. I am not using lateral position for the RPLND. So starting with now split and roll technique, incising the fascia over the IVC and separating the fascia over the IVC on the both side, so that IVC can be bared. So why we always start with the split and roll technique? Because all these post-ganglionic sympathetic fiber, they are in trunk form actually. So you won't find a plexus of these post-ganglionic sympathetic fiber behind the IVC. So it always becomes very easy to identify them. So you just saw the right renal artery as upper boundary of dissection, because this patient had a right testicular tumor. So I had to expose the right common iliac vein and right common iliac artery also. So once the mobilization of this complete IVC is done, I'll be just starting mobilizing the IVC, just rotating the IVC towards one side just to identify where are the lumbar veins. Now you can see I am taking out all the fascia across this IVC lateral margin, identifying the lumbar veins, taking with them with hemolock clip and cutting them, so that I can just mobilize this IVC from the retroperitoneum. So once there is a very small mobilization, I use bipolar just to hook all the IVC up above to open the retroperitoneum. And once there is a sufficient length which got mobilized, I take vascular tape and I retract the whole IVC with my third arm, retraction arm, that is progressed. So all these lumbar veins, they are all clipped, they are all divided. just to lift the IVC from the retroperitoneum so that I can see all these nerves, post-ganglionic sympathetic fiber. Now just you can see I am dissecting the L1 fiber, post-ganglionic fiber, just after incising the fascia. So once I can see this thing L1 post-ganglionic fiber, I am sure, I am confident now. Then I will proceed with the lymph node dissection at the interaortocaval groove. So I will just take out all these lymph nodal packets. I will go up to the prevertebral fascia to make sure that I am taking almost every lymph node which is at present into the interaortocaval groove. While dissecting, you may find some lymphatics which are coming across these lymph nodes, and it is very important to identify them and taking them with Hem-o-lok clip, clipping them and ligating them. Otherwise, the chances of having callus ascites is very high. So you have to be precise very much. So you have to identify all these lymphatics. You have to identify these post-ganglionic fiber because they are very thin also. Sometimes you may get confused between the lymphatics and post-ganglionic fibers. So once this dissection is being proceeded, so I'm just now up to this this right renal artery, and all these lymphatics which is coming from the upper abdomen to the interaortocaval groove across the right renal artery, they are being clipped and divided just to minimize the complication of or incidence of callus ascites. So if the burden is very low, you can see the anatomy of the retroperitoneum very beautifully. So you need not to be bare all these great vessels exactly. So you can preserve all these very small, tiny structures across the vessel. So now I am probably done with this taking out this lymph nodal packet. After taking this clip, that's it. So now I know where is my L1 post-ganglionic this sympathetic fiber. So just I will try to identify where is my L2 nerve. Now you can see this L2 post-ganglionic sympathetic fiber. And once you track them proximally, then ultimately by default, you will land up to the sympathetic chain. You can see all these nerves, they are merging into the sympathetic chain on the right side. So once I could see all this sympathetic chain and all this post-sympathetic post-ganglionic fiber L1 and L2. I am now pretty confident that I am in the wrong. I am exactly into the right plane. So now I will just go for the paracaval node because I am done with the interaortocaval and this precaval node. So you just could see this sympathetic chain along with the post-ganglionic fibers. I am just taking out all these paracaval nodes very carefully, and I will extend basically this field on the right side up to the common iliac bifurcation to the external and internal iliac. You could see also these lumbar veins on the right side. So you could see the sympathetic chain on the right side. So once I have dissected this paracaval lymph node, you can see this right ureter on the right side, the right renal hilum where there are two arteries and the vein. So the most difficult part is the basically pre-aortic space, because what happens, all this superior hypogastric plexus, which is situated over this inferior mesenteric artery, it is basically having all the lymphatics, lymph nodes, and the post-ganglionic sympathetic fibers. So you have to be very precise. So if you want to do nerve sparing, then you have to do berry picking exactly. So you have to identify the node, you have to berry pick it between all these post-ganglionic sympathetic fibers so that you should not injure this superior hypogastric plexus, because it doesn't matter if you have prevented these sympathetic fibers or sympathetic chain on the both sides. If you have injured the superior hypogastric places, then there is a very high probability that this patient will have retrograde ejaculation. So that is the very important step. So just I am taking this lymph node with berry picking technique, identifying, separating, teasing out all these fibers away from the lymph node. Now you can see all these sympathetic fibers going across this aorta into the pre-aortic space. Now I'm just left with this para-aortic lymph node. Just I am dissecting this para-aortic lymph nodal packet. So you will encounter all these lumbar arteries. Just take it with the Hem-o-lok clip. I always prefer to use 10 mm because I'm not confident with 5 mm because they get slipped very easily. Now you could see all these nerves, actually, the plexus, the lymphatics, along with these lymph nodes. So that's how it becomes very difficult to take out all these lymph node while preserving at the same time these lymph node, and not to have callus ascites in the post-operative period. But it can be done if you are having patience, you are doing your dissection very meticulously, taking your time. So they can be seen with the robotic magnification. and they can be very well teased off from the lymph node. You just apply the Hem-o-lok clip. Don't shy off applying the Hem-o-lok clip, because ultimately in the post-operative period, they just prevent you from having a callus ascites. And just I am taking all this para-aortic lymph nodal packet up to the left renal hilum. So you can see this left renal artery which is pulsating. I am taking out similarly from the right side and the interaortocaval groove. You can see this left renal artery and all these lymphatic which is coming across this renal hilum. So just apply the clip and cut them and just take out this para-aortic lymph nodal packet. And it is very important to understand the chance of having callus ascites is mostly because of injury of para-aortic lymphatic. So now you could see this sympathetic chain on the left side also, these postganglionic fiber on the left side also. So this is a right renal artery into the interaortocaval groove behind the left renal vein. This is the IVC. You could see the sympathetic chain, all these postganglionic fiber, L1, L2, L3. And this is the complete anatomy. So I am done with this nerve sparing RPLND. And this patient actually had 3 node positive, but I again asked him to take chemotherapy, but he didn't want to take chemotherapy. So I'm just observing this patient, and he is still doing fine. And he had antegrade ejaculation with normal semen volume after having this nerve sparing RPLND. Thank you for patience. If there is any question, I would be happy to answer them.
Thank you, Amitabh. That was a fabulous demonstration of RPLNDs. We'll keep the questions for the end. And now we'll go to the next talk. I would say the star talk for the evening by by Professor Aditya Bagrodia, who has extensive work on miRNA. And he would be talking on how the use of miRNA is shaping the management strategies in testicular cancer. Aditya, over to you.
Thank you so much, Gagan, for the invitation, and for the ISU for having me. It's been an absolutely incredible seminar so far. So I'll share a little bit on the state of the art of biomarkers in germ cell tumors. I do apologize. I will have to leave for my clinic shortly thereafter. So just important to remember that testicular cancer is responsible for the most life years lost of any non-pediatric cancer. It remains the most common cancer in men between the ages of 18 and 45. And here in the United States, we see approximately 10,000 new cases per year. And while the bulk of patients can be successfully cured with a combination of chemotherapy and surgery, nevertheless, approximately 500 patients die every year of testicular cancer. Staging, we heard about this earlier from Amandeep, maybe for the trainees that are on. Of course, stage 1 confined to the testicle, stage 2 in the retroperitoneum, and stage 3 would be disseminated disease. And of course, when it comes to testicular cancer, we have a S classification taking into account alpha-fetoprotein, human chorionic gonadotropin, as well as LDH. And while we are fortunate to have these markers as a part of our armamentarium, they do have some deficiencies. AFP can be increased in cases of hepatocellular carcinoma, liver disease, and familial conditions of AFP elevation. HCG is a nonspecific tumor marker and can be elevated in bladder, renal, gastric malignancies, lung cancer, excessive marijuana use, which is on the rise both here in the United States and internationally as well. And then in cases of hypogonadism, decreased testosterone can lead to increased LH, which cross-reacts with the HCG assay. And then LDH is quite nonspecific, and any clinical setting with rapid cell turnover is associated with LDH. Epidemiology here in the United States, approximately 85% of the cases of seminoma are stage 1, and stage 2 at 77%, and the survival remains excellent. And for non-seminoma, similarly, about 90% are a combination of stage 1 and stage 2. And it really becomes incumbent, we've heard about the evolution of testis cancer treatment, that we really minimize toxicity and maintain excellent oncologic outcomes, as the bulk of patients have early stage disease. And I would say that this falls squarely in the wheelhouse of the urologist and the urologic oncologist. So to kind of frame the talk, I'll run through the testis cancer journey. Of course, with diagnosis, we get ultrasonography and tumor markers. And tumor markers are elevated in approximately 60% of patients. And between a combination of a history, physical exam, sonography, and tumor markers, a correct diagnosis can be made in about 95% of patients. Again, at a very high level for stage 1, surveillance is the preferred option in the United States. For stage 1 non-seminoma, surveillance is the appropriate option. And notably, tumor markers are only elevated in approximately 3 to 10% of patients with seminoma at relapse and about 50% of patients with non-seminoma at relapse. When we move quickly into stage 2 disease, RPLND is rapidly becoming, I would say, the preferred standard of care here. And while we do these operations, nevertheless, in large surgical series, we see that 10 to 20% of patients are going to have pathological N0 disease, no lymph nodes identified that contain viable germ cell tumor at RPLND. And then the recurrence rate is also about 20% after RPLND. And then finally, in the advanced setting, following chemotherapy for both seminoma and non-seminoma, many times we do post-chemo RPLND, particularly for non-seminoma patients. We do these big operations, these heroic operations, as we saw with Dr. Anand, and half the time it's fibrosis, necrosis only. So what this really suggests to me is that across the spectrum, testis cancer is shrouded in uncertainty. The diagnosis, that's fairly straightforward, 5% orchiectomy for benign lesions, though. Stage 1 disease, this is the bulk of patients that present, and we really are trying to figure out who will relapse. In the stage 2 setting, we'd like to avoid any intervention for those with pathological N0 disease, and we'd like to personalize treatment approaches to those who would likely develop metastases. And then in the post-chemo setting, who are the patients that would actually benefit from surgery? If we had sensitive and specific biomarkers, this could allow for precise, individualized treatment recommendations. And over the second portion of this talk, I'll discuss how circulating microRNA 371A3P holds the promise to be such a biomarker. So what are microRNAs? These are small non-coding RNAs involved in epigenetic gene regulation. They're released from the nucleus after several processing steps. They mediate intracellular communications, and notably, they are dysregulated in many malignancies. When it comes to germ cell tumor-associated microRNAs, almost 15 years ago, Palmer and colleagues reported a gene expression study looking at normal gonadal tissue, viable germ cell tumor in both pediatric and adult patients, as well as teratoma, and they identified a 8-family member of microRNAs that was consistently overexpressed in the germ cell tumor patients and not expressed in normal testis tissue, and notably not expressed in teratoma. This same group, the following year, reported on a patient. He was a 4-year-old with a sacrococcygeal yolk sac tumor. His AFP was 80,000, and these authors obtained serum from this young man, and using pre-amplification followed by qPCR, were able to detect each of these microRNAs in the serum of this young man, track it along with treatment, and then finally correlate it with final post-chemo histopathology, which was fibrosis and necrosis only. This study led to fairly significant international interest in germ cell tumor-associated microRNAs, and one of the first studies from Gillis and colleagues published in 2013 with 161 patients, 91 of those with malignant germ cell tumor, 70 with controls. And for the first time, they reported sensitivities and specificities that outperformed conventional tumor markers, and notably were elevated in a substantial proportion of patients with seminoma, where tumor markers have been largely uninformative to date. And now I'll talk a little bit about where things stand with respect to microRNAs across the disease spectrum. This is one such study from our group where we looked at pre-orchiectomy microRNA tests in a heterogeneous group of patients prior to orchiectomy. And in this study of 69 patients, 58 viable germ cell tumor, 11 control, a distribution of Caucasian and Hispanics here in the United States, as well as a distribution between seminoma and non-seminoma. And what we identified was that the sensitivity and specificity of microRNA 371 was 93% and 100% respectively, with an overall accuracy of 94%, well outperforming conventional tumor markers, which were at 65%. In the largest study to date, Klaus-Peter Diekmann and colleagues reported on 874 patients, 616 had cancer, 258 controls, and you can see here that the areas under the curves, largely in the pre-orchiectomy setting, were really outstanding for all comers. It was 96, for stage 1, 95, and for stage 2 and 3, 99.6. So there's lots of data out there, but suffice it to say in the pre-orchiectomy setting, 371 has excellent performance, and it performs better than conventional tumor markers. Now, really moving into the area of largest unknown, in my opinion, is the stage 1 setting. And I would maintain that current risk stratification is insufficient for individualized patient counseling. As previously mentioned, for patients with non-seminoma, we look at lymphovascular invasion and a high degree of embryonal carcinoma predominance. And if you have these risk factors, there's approximately 50% chance of occult metastases. In seminoma, fairly rudimentary risk factors, including size greater than 4 centimeters, ready testes invasion, which increase the likelihood of metastases to 30 to 40%. So to frame this, I'll share a patient of mine. This is a 24-year-old with a stage 1B mixed non-seminoma germ cell tumor. He was actually counseled towards observation, but for a variety of reasons, he elected for primary RPLND. And indeed, he had a focus of embryonal carcinoma that was 0.5 centimeter in one of 33 lymph nodes. We obtained a pre-RPLND microRNA, and that was positive. What does the data show? So again, this study from Dr. Diekman and colleagues, where they had 316 patients that were stage 1 disease. In a subset of patients, they had matched pre-orchiectomy and post-orchiectomy microRNAs. And in the patients that have persistently elevated post-orchiectomy microRNA, the sensitivity and specificity were 83% and 96% respectively. In a separate study by Sia Danishmand, Lucia Nappi, and colleagues, they focused on patients with stage 1 disease, and a 371 assay was able to correctly identify all patients that ultimately recurred and those that did not. Considerable excitement here, a little bit of a pause on the brakes. Rob Hamilton and Zhao Lobo presented a study of 151 patients, the relapse rate precisely what we'd expect at about 23%. And there was no association between an early post-orchiectomy microRNA and ultimate relapse. However, at the time of relapse, 94% of patients did have an elevated microRNA. Carrying this work a bit further, Christian Fankhauser reported on a prospective study of 33 patients, stage 1 disease. Serum was serially collected over surveillance. A relapse rate, again, very consistent with reports in the literature at 30%. And these authors found that an early post-orchiectomy microRNA did not indicate relapse. However, it did appear that microRNAs were elevated approximately 2 months before clinical detection. And whether that would allow for some type of de-escalation strategy is the area of ongoing research. So in the stage 1 disease, I would say that 371 is promising to detect relapse. However, an early post-orchiectomy microRNA may not predict relapse, and this is likely a sensitivity issue. In the stage 2 disease, again, I'll share a patient case of mine, a 44-year-old with a right-sided testis mass, mixed non-seminoma germ cell tumor. You can see here on the imaging that somewhat unusually he had para-aortic lymph nodes that were enlarged. We repeated imaging in 8 weeks with no change. And ultimately, the patient elects for a bilateral full template RPLND with 2 out of 32 lymph nodes with small foci of seminoma. And this man also had a positive pre-RPLND microRNA. So when we look at the data in the stage 2 setting, this was led by John Laffin. And serum was prospectively collected on 32 patients prior to chemo-naive RPLND. And histology was classified as either benign, viable germ cell tumor or teratoma only. Kind of classic what we'd expect. Composite clinical stage was 2 in approximately 63% of patients. And at final histopath, 70% of patients did indeed have disease. And what we see here is that microRNAs perform quite well with the sensitivity of 0.92 respectively and area under curve of 0.93. In the stage 2 setting, where we do have a sufficient bulk to produce microRNAs emitted into the circulation, I would say that they're quite promising for the avoidance of a negative RPLND in those destined to be pathological and 0. As we saw by Dr. Anand, sometimes we do these heroic surgeries, and half of the time there's no cancer. As mentioned previously, microRNA 371 does not detect teratoma. So, starting with the case again, a 25-year-old with left-sided back pain, 8 centimeter retroperitoneal mass with marginally elevated tumor markers and a mixed non-seminoma germ cell tumor. He got chemotherapy, and then at post-chemo RPLND, he had a small focus of embryonal carcinoma. And his pre-RPLND microRNA was also positive. The largest series looking at viable germ cell tumor in the post-chemo setting comes from Rob Hamilton's group, 82 patients receiving post-chemo RPLND, 40% with fibrosis necrosis, 34% teratoma, and 12% viable germ cell tumor. And these authors report that microRNA 371 could reliably detect viable germ cell tumor with an area under the curve of 0.88. Now, while we do see viable germ cell tumor in a small proportion of cases, it's really the teratoma that is the most common histopathology. In 2016, the Testicular Cancer Genome Atlas was published, and microRNA 375A3P was overexpressed in 6 out of 9 teratomas. Our group took a cohort of 40 patients receiving post-chemo RPLND, half with teratoma, half with fibrosis necrosis. And when we looked at the 375 3P arm and the 5P arm as well, you can see the areas under the curves are right at 0.5, uninformative for clinical decision making. We expanded into small RNA sequencing from the same cohort. There were 3 candidate microRNAs that were overexpressed. However, on PCR, we were not able to validate any of these. So in the post-chemo setting, I would say that 371 is promising for the detection of viable germ cell tumor. However, to date, there is no reliable circulating test for the detection of teratoma. Really tremendous work that's been presented and published by multiple groups out there across disease states. And as it stands, I would say that accurate patient-level risk stratification is critical for appropriate treatment, avoiding under and over treatment. Novel means are required to accomplish this goal, and microRNAs are truly poised to impact the way patients are diagnosed, treated, and surveyed. There's some work to be done with standardization, optimization, and validation. We actually have microRNA available here in our CLIA certified lab, and it's actually absolutely been a team sport over the last 10 years of my career. Thank you so much.
Thank you, Aditya. I think probably this will be the biggest step in terms of de-escalation and reducing toxicity and unnecessary treatment over the years to come. Since Dr. Aditya has to leave after this, would there be any questions we can take for him? We can take the questions right now.
So I'll also put my email in here if there's any follow-up that people would like to discuss.
Dr. Aditya, I have one question. So if you really want to do a microRNA test in a post-orchidectomy setting, so how many weeks or days we should wait to do this study?
Yeah, I mean, minimum would probably be 6 to 8 weeks, and that's going to generally coincide where surveillance imaging would be performed. And these data are also kind of being teased out, Dr. Mehta, where, we know in the pre-orchidectomy setting, nearly uniformly, there are measurable amounts of microRNA. The half-life consistently seems to be in the 4 to 12-hour range. Of course, the pre-orchidectomy microRNA and the decline would be dictated by the amount that was in the pre-orchidectomy setting. And there's not really great quantitative tests, like we don't have international units or nanograms per deciliter for AFP and HCG. So I would say that that's being borne out. And there's one clinical study, AJCT 1531, which actually has multiple time points for collecting serum immediate post-orchidectomy at 2 weeks, 4 weeks, 6 weeks, 8 weeks. And I think that's going to probably give us a better sense of the actual kinetics.
So the whole idea of asking this question is if it can give the better idea than the tumor markers, what we normally, traditionally what we do. So if we can have idea very early after post-orchidectomy status, then that will be a good prognostic feature for patients. No? They would like to come to know what is happening, what I'm going to do.
Absolutely. And I think, this is a sensitivity issue. The nearly certainly the occult micrometastases in the stage 1 setting exist. The assay as it currently stands, I would say, is insufficiently sensitive to pick up an early micrometastatic recurrence in, the 6 weeks or so after the orchiectomy. But I have no doubt that this is a technically solvable problem, one. And two, while microRNAs kind of are the marker du jour, there's also new exciting technologies like bespoke cell-free DNA assays that have some potentially better sensitivity in the early post-orchidectomy setting.
And the second question, if you are not, ready to go. So, say for example, in bladder tumor, we usually go for multiple microRNA testing. But for a testicular tumor, is it the only one, or because you one study you said that there are 8 microRNAs which were tested by the authors. So, what is your proposal? Should we go for only a single microRNA or multiple microRNAs?
Yeah, so the 8 panel was first described, and then it was really felt that the 4 members, 371 to 373 and 367, were actually the most informative. And actually, the individual performance of 371, which incidentally is a universal germ cell tumor marker, adult and pediatric germ cell tumors, male and female germ cell tumors, gonadal and extragonadal germ cell tumors. So, kind of like I12P, it's the first universal molecular hallmark. And the value added of and the cost, you could say, of the additional microRNA seems to be fairly trivial.
Dr. Aditya, I had a question, Anand here. So how far away are we from using the microRNA in routine clinical practice going ahead?
Sure. So quite a bit of work to actually, it's a finicky assay. It's not a straightforward assay. And I know that the group at Data has some experience with this. We, in the United States, it has to be in a certified laboratory with reproducibility, dilution curves. And we've kind of gone through that process as of April of this year. And, I can order a test on a patient in clinic later today to make a clinical decision. There's probably lab-specific peculiarities. There's probably disease state-specific features that are to be taken into account. And right now, it's the center of multiple clinical trials. We have a stage 1 trial based on microRNAs. If you're negative, you're observed. If you're positive, you go on to RPLND. And then now that we have it available in a CLIA context, we're getting it in addition to imaging and serum tumor markers to see, can we replace imaging completely in patients with seminoma, for instance? Can we maybe space out some of the CT scans in patients with non-seminomas?
Thank you.
Thanks, Aditya. I think
He has to leave.
yeah, we can probably he has to leave, and I think we are also running
Just
late.
one small question, if you allow me. So
Sure.
you know the tumor markers all depend on the histology. So whether it is a choriocarcinoma or embryonal carcinoma, so they are histopathological type specific. Are the microRNAs type specific, or except you said that teratoma, it cannot diagnose teratoma. So is there any different levels for different pathological types?
The short answer is generally not. Seminomas seem to have performance characteristics that are just slightly lower, 3 or 4 percentage points on an area under the curve than non-seminomas. Now, I do think they will be complementary to existing tumor markers. For instance, if you do an orchiectomy, pure seminoma, and the AFP is 50, and your concern or suspicion is that it's a non-seminoma, that wouldn't be something that you could glean from like a microRNA test. So I think they'll be complementary. And maybe to answer the last question from Dr. Parth Manik, would microRNAs be included in staging like STMs? It's an interesting thought, right? We do these orchiectomies, we do these RPLNDs when the microRNAs are positive, and we feel quite good that we can detect the patients likely to benefit from disease. And I actually think we're going to really rethink about how we approach patients with measurable tumor markers, because it is just another tumor marker suggesting the presence of disease. And, could we actually spare 60, 70% of those patients chemotherapy with surgery? So I think, how this incorporates into our existing tumor marker paradigm is, to be determined and very exciting.
Thank you, Aditya. And those of you who've loved Aditya's voice, he's also the voice behind the Backtable Urology podcast. And I would recommend all of you to go and listen to some really, really great episodes encompassing urology and beyond urology as well. Thank you, Aditya, for joining.
Thank you.
We would now go to the next talk by Professor Amit Joshi, who's also a colleague and head of our Actric Hospital in Navi Mumbai, and he would be talking about the long-term or the late toxicities, and also the concept of survivorship with this cancer, which is very, very unique to this cancer. Dr. Amit Joshi.
Thank you, Gagan. I hope I am audible and my slides are visible.
Yes, sir, just make it full screen.
Yes. So just a quick review of because the time allotted is only 10 seconds and this topic is for the whole day discussion.
10 minutes,
tried-
not seconds. 10 minutes, not 10 seconds.
10 minutes, yes. So we'll just start. So just a quick background. We all know that testicular cancer is a disease with a high cure rate of more than 95%. In all the three modalities, surgery, chemotherapy, and radiation are being used to cure these patients. And as majority of the patients are at young age, between 15 to 25, they have a long window of survival, and whatever the long-term complication of a chemotherapy, radiotherapy, or surgery can be seen in those patients. And these long-term complications will affect the quality of life in this patient because they have a long life to live. So this has led to the concept that a delicate balance must struck between the optimizing cure and the minimizing the long-term complications. So we all know about this WHO health definition that health is a state of complete physical, mental, and social well-being. So when we treat any patient from for the testicular cancer, either with chemotherapy or a radiation or with surgery, we definitely control the physical aspect of that. But even after the cure of the disease, the mental and social aspect are also being overlooked in oncological setting, and especially in testicular cancer, where the survival is going to be a long mental and social well-being also. So these are the concept for the what we call as the survivorship. Physical component is initial component. We treat the patient, we cure the patient, but long-term mental and social are the other aspect which has to be looked in these testicular cancer patient. So this is just a quick schema of seminoma patient. And
Sir,
in our scenario, majority of the patients.
Sir, can you make the slide full screen? The slides are not moving.
Yeah, so we
Sorry?
Yeah,
the slides are not moving actually.
Yeah. And you have to make it full screen and we are not able to see your slides.
Gagan, I think it's, do you able to see the slides now?
No, we can see only the first slide. It is not moving. So either you stop the, yeah, now it is moving. And if you can make it full screen.
Now it's visible?
No, it's only one slide.
No, you have to go to full screen mode.
This is the first slide.
Yeah.
Second slide.
No.
No, should I stop share and reshare?
Yeah.
Maybe that's better.
Now it's moving.
No, make it full screen.
Yeah, it's full screen. Can you see in the half screen?
Yeah, okay. So you can, yeah. I'll keep telling you to go to the next slide, yeah.
Let him continue with this only.
Okay.
Yeah, I think.
Yeah.
So why this all chemotherapeutic drugs has some or long-term toxicities? The most important chemotherapy regime which is being in testicular cancer is BP regime, which has cisplatin, etoposide, and bleomycin. We also use the TIP and the VIP regime. But since the BP is the most common regime, and all three elements of a BP regime have some or other long-term toxicity. Cisplatin causes directly damage to the vascular wall, which leads to the increased risk of thrombosis and secondary vascular event leading to the cardiovascular event and the strokes. Cisplatin also causes nephrotoxicity and neurotoxicity by damaging the proximal tubules leading to the ATL and directly damaging the nerves, which causes the long-term neurotoxicity. The etoposide in the BP regime causes the translocation of MLL gene, which is implicated in the pathogenesis of secondary leukemia. Similarly, the bleomycin in the BP causes lung injury through the oxidative mechanism as the lung tissue lacks the bleomycin hydrolase enzyme, which is needed for its metabolism. So all the three drugs have some or other possible potential causes to cause the long-term toxicity. Just quickly revising the major late complication and their frequencies. The first will start with the second malignancy, which may be a solid tumor or mostly it's a leukemia, which is related to the etopocyte-related secondary malignancy, which is seen in close to 6% of the patient. Similarly, the cardiovascular disease, which is seen in close to similarly 6% of the patient. The hypogonadism, which is related to the baseline hypogonadism, which is seen in testicular patient from the baseline, and the chemotherapy, which is causing the damage to the testicular tissue, leading to the hypogonadism, especially the agiospermia and the oligospermia, which is seen in close to 50. If you see the incidence of hypogonadism, it is close to 50% in long term in these patients. The bleomycin-related lung toxicity, it is close to seen in 5 to 8% patient. The incidence of dyslipidemia, which is very high in this patient on follow-up, it is close to 85%. Similarly, the hypertension, Raynaud's phenomena, renal impairment, and ototoxicity. And if you see the time duration, it is on an average is 3 to 5 years. So after completion of the treatment, patient is cured of the disease, but they are at risk of developing these complication on long-term follow-up, and that is the reason these patients needs a constant long-term follow-up to pick up these complications early and then treat them. At least some of them are definitely treatable. So these are the complication and how this complication presents in the OPD, the neurotoxicity, which is related to the cisplatin use and paclitaxel use. This a patient may present with on a follow-up, may present with a tingling, numbness and pain in the foot. The ototoxicity, which is related to the use of cisplatin, this may present with a high frequency loss, and patient or family member can present with that the patient is not able to understand when there is a loud sound around, and this is the reason that when on follow-up, if any patient presents with some sort of a hearing difficulty, we need to check it with the audio, the pure tone audiometry, and there are certain devices which helps patient to go for a normal life. The nephrotoxicity, as the patient has mostly received the cisplatin for 4 cycles, definitely in long term, the serum creatinine needs to be monitored. And if patient is having some sort of a renal dysfunction, the nephrologist opinion has to be taken, and other nephrotoxic drugs seems to be similarly, the cognitive impairment, which may be related to the chemotherapy use or because of the psychological issues, these have to be looked on follow-up. Similarly, the Raynaud phenomena, which is secondary to the bleomycin use and presents with the excessive cold feeling in the hand and feet. So, second, that why I discussed the second malignant neoplasm. Whenever the patient presents with a unexplained symptom, weight loss, the second malignancy has to be looked into that. Similarly, the patient on follow-up, this blood sugar, lipid profile, hypertension, that needs to be checked, and appropriate measures has to be started to prevent these complications. So, if you see the other long-term complication which may be seen is the testosterone deficiency, which may be because most of the time with the unilateral orchidectomy, majority of the patients are able to maintain the testosterone level, but still some patient who presents with a excessive fatigue or any other symptom like muscle mass loss, the testosterone level need to be checked. Fertility is very important component because of the chemotherapy and a hypogonadism, 50% patient, and the surgery which might have led to some sort of a retrograde ejaculation. So 50% patient might not able to go for a fertility after the completion of the treatment. So as a routine, we all consider for a sperm banking preservation before starting chemotherapy in these patients, because 50% patient may need some fertility support at some point of time. So this is one of the preventive measure which we can do in patient before starting chemotherapy, that we should go for a sperm preservation before proceeding. And the other very important aspect, that psychological issue which is very much neglected in our BGOPD, that after completion of the chemotherapy, patient is still not able to go back to the normal life because of the psychological trauma they harbored during their treatment, relations issue, return to school, and definitely the sexual dysfunction, which may be because of the surgical related issue. So apart from curing these patients, the psychological issue play a very, very important role in follow-up the patient, and ideally on follow-up these patients should be checked. So if you see of a good survivorship program. So when patient comes to our OPD on follow-up, medical oncologist only one part of that their management on follow-up. We need a whole group of other supportive staff to take care of this. So if we check for the subspecialty on the follow-up or for a survivorship, it should be a cardio-oncology, it should be a specialist from the onco-nephrology, onco-endocrinology, the onco-fertility, which is very important, but we have realized over a period of time, nutrition and exercise counseling, sexual health counseling, sleep counseling, tobacco cessation. So these are all specialties are part of a survivorship program whenever we see any patient for a on the follow-up during this. So in Tata Hospital, we have a Menken initiative. Under this, we run a adult survivorship clinic. Possibly, it may be the first of its kind for a, especially for the uro-onco patient, the testicular, prostate, and the penile cancer. It runs every first and third Friday, 10 to 1 a.m. In this survivorship clinic, we call the psychiatrist, career counselor, nutritional counselor, the onco-fertility expert, sexual health expert. So the treatment of testicular cancer doesn't end at the time of completing the treatment. The physical treatment stops, but the other long-term survivorship starts. And these are the specialty which needs to be in a survivorship clinic, the psychiatrist, dietitian, career counselor, sexual health specialist. So in a day-to-day, it is not possible to manage these patients. We need a dedicated space, dedicated team to give these patients not only the physical cure, but also the psychological and mental support. Thank you. Thank you for your time.
Thank you, Dr. Amit Joshi. And that brings us to the last talk of the day, which I would be taking. How do I go? I hope it's seen now. Is this?
Yeah, Gagan, go ahead.
Yeah, okay. So the talk is called What Not to Do in Testicular Cancer Management, the 10 Commandments. And this is on behalf of our disease management group. This is, I would say, a realization that we have had while sitting in our multidisciplinary clinics and seeing things and stories which happen to these patients, which can sometimes adversely affect their otherwise very good surgical outcomes. So we register around 250 to 300 patients over a year and consistently have been doing around 40 to 50 RPLNDs in a year. And these are some of the lessons that we've learned over the years. So I'll speak about these 10 important points which you can probably carry home. Number 1, thou shalt not miss examining the scrotum in a young male presenting with abdominal mass. Whereas this is a classical teaching, but unfortunately, we still have 4 to 5 patients in a year where we see that somebody has done a laparotomy, taken a biopsy, came out, and in the post-operative period realized that there was actually a testicular tumor. Number 2, thou shalt not violate the scrotum or miss the history of having already, or that the scrotal violations has, or something like a hernia surgery has already happened in the childhood. Sorry. Why is this not moving? Yeah. So, you would realize that we've realized that almost 16% of our patients still present with a scrotal violation. That means somebody is operated upon this on the testis thinking that this is an hydrocele and then realize that this was actually a testicular cancer. Now, if the patient doesn't receive a chemotherapy later on, that is stage 1 cancers, and when we do the revision surgery, we realize that almost 60% of these patients would harbor disease. Whereas if the patient have received the chemotherapy, then only 4% of the patients, this number drops down to 4%, where residual disease would be seen. Number 3, thou shalt not miss the retros on imaging. So remember 3 retros: retrocrural nodes, retrocaval nodes, retroaortic nodes, and also the retroaortic renal vein, the importance of which has been emphasized by Anand also in his videos. Again, a number to tell you that 1 in 4 retroperitoneal patients would have some kind of an aberration or anomaly in the vasculature. It is much more commoner than we think. Number 4, thou shalt not hesitate in starting chemotherapy before orchidectomy in patients with high burden or symptomatic disease and an unequivocal diagnosis. So essentially a scenario where you see that a young patient comes with extensive disease, long of lung metastasis or heavy burden disease or symptomatic, you do not have to follow, the classical steps of first we will do the orchidectomy, wait for the orchidectomy to heal, and then go for the chemotherapy. In such patients where the markers are high and the disease burden is high, you can straight away go for the chemotherapy. And this is something which we've kind of, analyzed at our center. And what we found is that the blood test is barrier, which was the reason why it was said that first do the orchidectomy and then do the chemotherapy. That gets breached in almost half of the patients because we often see large tumors. So the barrier doesn't exist, which means that in half of the patients, when the orchidectomy was done after the chemotherapy, we found that there was no tumor left. So the tumor was actually reaching the scrotum and affecting on the primary site also. So what we are suggesting that in these set of patients, we can change the sequence. Instead of high angle orchidectomy followed by chemotherapy followed by RPLND, you can do the chemotherapy upfront and then do the RPLND and the orchidectomy together. Number 5, thou shalt make all efforts to not overtreat stage 1 and stage 2 cancer. And this is something which Aman has also emphasized. I just wanted to say that I think this common reason that we say that Indian patients or patients, many of our patients are not compliant, and that is why we should just give them chemotherapy, is something which we should probably change. We should rather work on mechanisms to ensure that the compliance is there. Thou shalt not perform FDG PET in NSGCT and not before 8 weeks after completion of chemotherapy in seminoma. So we know that there is a role for doing a PET CT in seminoma, but understand that the moment you do that PET scan before 8 weeks, it is going to misguide you and you would not be able to take the right decision. So you have to give adequate time in seminomas after the chemotherapy before you do the PET scan. Number 7, thou shalt not continue giving chemotherapy for multiple cycles after the tumor markers have normalized. And thou shalt not give radiotherapy to retroperitoneal masses in NSGCT because the surgery looks difficult. So believe me, this is something which again we see not very uncommon. Patient has received 10 cycles of patient chemotherapy. Patient has received 12 cycles of chemotherapy, far more after the tumor markers have normalized. So please understand that any endeavor to reduce the size by giving chemotherapy once the markers have normalized is not going to work. The only thing which is going to make things different is a good RPLND. The same thing with radiotherapy. Non-seminomatous germ cell tumors are not radiosensitive. So, I mean, and we've seen people receiving radiotherapy so that, if this disease is, if the surgery remains difficult or looks difficult, just give radiotherapy to it. That's not what has to be done. And as we already discussed, they are hardly inoperable. It's just that the patient has to reach centers of excellence in doing this. Number 8, thou shalt not miss actively looking for bleomycin toxicity. So understand that bleomycin toxicity has to be digged into. One has to find that it is there or no. We've had instances where the patient has had an extensive surgery, the surgery was uneventful, and the patient had a perioperative mortality because of the bleomycin toxicity, which kind of surfaced after undergoing the major or the supra major surgery. Number 9, thou shalt not do a robotic RPLND unless you have considerable experience in both open RPLND and robotic surgery as a combination. So, if you are a very good robotic surgeon, but you haven't done many open RPLNDs, then probably you should avoid it. Also, if you've done many open RPLNDs, but your skills and robotic surgeries are still, not up to the mark, then probably this surgery is something you should avoid in robotic. If you are doing it as a robotic RPLND, then thou shalt handle the specimen with extreme care within the abdomen. If the spillage has to be avoided. So understand that in different tumors have different kind of reactions to the way they behave to pneumoperitoneum is different, and germ cell tumors, viable tumors can really spread within the peritoneum if there is any tumor spillage. And there have been warnings about this in paper, and we've also burned our fingers in a patient. Number 10, thou shalt make all intraoperative efforts during RPLND to avoid common complications. In our series of around 350 RPLNDs, the commonest complications are ileus and chyle leak. So chyle leak is something which was demonstrated by Amitabh also. You have to specifically look and clip that. And the other thing was about sparing the nerves as much as possible, which is again an intraoperative step. And if the nerve sparing RPLND is well done, then the rates of antegrade ejaculation at 1 year are above 65% at our center. Thank you.
Yeah, thank you very much, Gagan. So it was an excellent webinar, and as usual, you had such a nice combination of speakers, and you really have thought of very good topics which kept us excited till this time. And I really am thankful for you for compiling all of them and inviting them. It was really an excellent webinar, I'm sure, and it would be available on USI YouTube for people who missed it and students who are doing their duties and taking rounds. So thank you very much, everyone, and we look forward to further more nice webinars from in the future. I had just one small query. This men's I mean the cancer initiative program which you have started, is it open for other people also, like because it's in Mumbai, can other institutes in Mumbai also participate or send their patients there?
Absolutely, madam. So the support group for all these patients, all these survivors is open to everybody. Even if the patient is not registered in Tata, even if the patient has been treated elsewhere, they are open
Yeah.
to, we are open to that.
Yeah, yeah. Okay. Thanks a lot. Thanks a lot, Gagan. I'm really very pleased and very happy that this webinar has turned out so well. So thank you all the participants and all the speakers. They were excellent talks by Dr. Amandeep and Gagan himself and Dr. Aditya, and obviously the surgical videos of Dr. Amitabh and Dr. Anand kept us like wanting for more. So I thank Dr. Uttam Mete for being in this seminar till the very end, and for his keen interest in all our webinars. And thank you all the participants for your presence. So I think we can end, Gagan.
Yeah, thank you. So, I mean, although we had kept some time for Q&As, but I think we've really exceeded the time. I've kept away from the dinners actually. So
No, but definitely no problem. We can continue. It will be available on YouTube, and people can post their comments there and questions there.
Yeah, just 2-3 minutes. Can we continue?
Yeah, sure.
Just
Sure,
2-3
sure,
minutes.
sure.
Because we didn't have any question answer session, only except Dr. Aditya. But anyway, time is the limiting factor. It's a dinner time, and our principal, Dr. Sujata, is not going to offer us. She will offer
No, sure, you
virtual.
can continue. I am also interested in asking Dr. Anand so many questions because I was thinking I'll email him instead of that.
Okay,
Yeah,
so
please do ask.
Dr. Raja had shown those videos. So we do quite a bit, not as good number as Dr. Gagan is doing RPLND. So for advanced stage post chemotherapy RPLND, sometimes definitely you have to excise the IVC and aorta and replace it with this graft. So how can you preoperatively predict that this patient most probably is going to likely to require a graft, and what is your arrangement for that, a vascular surgeon and other stuff?
Gagan, you want to take that, or do you want me to take it? How?
No, Anand, please take it.
So, the involvement of the IVC really depends. If you can, this we've evolved over a period of time. If you can see that there is one nodal mass which is directly infiltrating into the IVC, then that case would probably require an IVC resection. But sometimes you're able to make out that rather than one nodal mass, there are these multiple conglomerate nodes that are kind of pressing the IVC from, from all the sides. So even though a long segment of the IVC is not seen, when you dissect it out, it's just multiple nodal masses are compressing it. I think that's a very fine distinction that comes with a little bit of experience. Now we are able to fairly tell, what masses we might probably require resection and what are the masses that you get away with. When we anticipate that there is a good risk of resection of the IVC, we keep a vascular surgeon on standby. Although now we've started doing the vascular resections on our own, but to be on the safer side, we keep the vascular resection on standby whenever we anticipate one of these things.
No, I think apart from that, I don't know what is your opinion about the circumferential involvement. So if it is for aorta, if it is more than 330-degree involvement, I mean more or less 360-degree or 330-degree. So and an IVC maybe more than 135 or 140-degree. I don't know what is your opinion. Like preoperatively from radiology, you can predict that given patient most probably, and that is the question. So whether you believe in these figures or not.
No, sir, I don't deal in these numbers. The aorta is because the aortic wall is usually so thick that it prevents it's a big barrier to the growth of the tumor into the aorta itself. So the aorta usually is never infiltrated. As for the vein, like I said, I don't go by this 180 or 90 or 360-degree encasement. I look at whether it's one node or multiple nodal masses which are compressing it, and based on that, I take a call. I don't know what Gagan does.
Can I ask you one question, Dr. Dr. Anand Raja?
Yes, please. Yes, please.
Yes. So, have you noticed that the RPLND is done in 2011, 12, and those boys had more bleomycin toxicity compared to now? And is it because of a shift in our, like now we do RPLND upfront and not post chemotherapy?
No, we don't. I have not seen that shift, and we've done most of our RPLNDs post chemotherapy. The upfront RPLNDs that we are doing now is what was told by the speakers. Maybe in some of those very early stage ones, and sometimes stage two is when we are starting to do the RPLND, especially robotic. But most of our RPLNDs are post chemotherapy. We don't do the upfront RPLND, maybe except a very small subset, and that too now.
Okay. Thank you.
Thank you.
Bye-bye.
I think Gagan has a lot of things to say about the IVC and everything else. I think he's an expert in that, and we keep discussing with Gagan.
Yeah. Okay.
There's just one question I wanted to ask Dr. Valentina, which was, so you mentioned that in some parts of the world, particularly Scandinavian countries and Europe, there's actually a rising incidence, and we can see that. And there was some comment by Dr. Mete about, this is a cancer which probably would never need a screening. Although the screening in terms of clinical examination is a very easy thing over here. Do you think that the countries in which the incidence is actually rising at an alarming rate, are any of them promoting, beyond just an awareness campaign? I mean, promoting like a screening for these in the 20s and 30s male?
No, I think no. Well, I'm not sure of this, not in my knowledge. No, there isn't an increase in screening in these countries. But well, probably there is an improvement in some registries, so more data from registries. But I think this is not enough to explain the increase in incidence. I think there is also an increase in the risk factor, probably still unrecognized. due to changes in the world, due to globalization, so migration, changing in socio-economic factors. So I think there is a contribution of more data, probably more screening in some countries, but also there is something that is changing in environmental exposure to risk factor.
Thank you. Thank you. I think we'll wrap up this evening and
Yeah, I forgot
thank
to
you.
thank Dr. Valentina, so I'm really grateful for your lecture too. Thanks a lot for participating.
He was
you,
there
thank you.
throughout the webinar.
Yeah, she's there throughout the webinar.
Okay.
Yeah, thanks a
Anyway,
lot.
thank
Maybe
you.
like breast examination, self-examination of testes can be done instead of screening. A monthly examination of the breast is usually advocated for females.
Only one comment from Dr. Gagan's presentation. It was very harsh to compare those testes with akhrots. Okay.
That's because ChatGPT does not allow you to depict a testis ka picture.
Okay.
Okay.
Okay, thanks a
See you
lot
then.
and good night. Thank you, everyone. Thanks, Surya.
Thank you,
Bye,
madam.
bye, bye, bye.
Yeah, bye.